Capsular bag distension syndrome is a visually significant complication after IOL implantation in the bag. In the setting of a perfectly circular rhexis, capsular distension syndrome occurs when the intraocular lens moves anteriorly and physically closes the rhexis from inside, thereby trapping fluid and OVD behind the lens. Capsular bag distension syndrome has seen an increase in incidence due to the reduced diameter of capsular rhexis. With various anterior capsulotomy innovations and increased awareness regarding the need for uniform capsular overlap, anterior capsulotomy with reduced diameter has become the new norm. Moreover, in pseudo-exfoliation syndrome, a three-piece IOL is implanted in the sulcus with optic capture by the anterior capsular rim. These two situations, particularly with retained OVD, are associated with increased risk of capsular distension. Early capsular distension syndrome, that is in the first few days after surgery, often goes undetected. This results in a myopic surprise, shallow anterior chamber, and occasionally raised IOP. Misdirection of BSS into the bag during hydration of the wound at the end of surgery is an important contributing factor. A careful slit lamp examination is all that is needed to pick up this issue. In contrast, late capsular bag distension syndrome presents several years after surgery with defective vision, and examination at the slit lamp reveals turbid fluid trapped behind the IOL, distending the capsular bag. Some may have cheesy white material which are derived from the residual epithelial cells. Most of these cases are likely to be early undetected capsular bag distension syndrome. Late capsular bag distension syndrome is often mistaken for opaque IOL, where the IOL loses its transparency due to physicochemical changes in the optic. In capsular bag distension syndrome, the transparency of the IOL is not altered. Current treatment modality for capsular bag distension syndrome is yard laser capsulotomy of the anterior or posterior capsule. Posterior capsulotomy is technically easier, but with the known risk of RD, CME, and propionibacterium endophthalmitis. Coming to prevention, near complete aspiration of OVD from the bag after IOL implantation is a crucial step in minimizing this complication. Lifting up the optic and aspirating with low parameters is to be done to ensure a clean capsular bag. IOL implantation under continuous irrigation will ensure that very minimal OVD is left behind in the bag, which can be easily aspirated. A peripheral capsulotomy created using a diathermy needle was described in a letter to the editor in JCRS 2004, the only mention of a similar step in published peer-reviewed literature. In patients with high risk of capsular bag distension syndrome, like sulcus fixated IOL with optic capture in an intact capsular bag, eyes with greater axial length, or a smaller rhexis, a peripheral anterior capsulotomy can be created with a needle. A fresh 26 gauge capsulotomy needle is used to create a small opening in the anterior capsule peripheral to the edge of the optic after IOL implantation. The irrigation handpiece introduced through the sideport maintains the anterior chamber with continuous irrigation and helps in retracting the iris. The opening so created acts as a channel for communication between the bag and the aqueous, reducing the chances of capsular bag distension syndrome. An increased awareness of capsular bag distension syndrome will help the surgeon to pick up these cases and manage appropriately. Apart from complete OVD removal, a simple step of peripheral anterior capsulotomy in high-risk cases will completely eliminate it. In the current cataract surgery scenario, where there is increased emphasis for the perfect round rhexis and 360-degree overlap of the optic by the rhexis edge, we feel this simple step will be a useful tool in the surgeon's armamentarium.